I can't tell anyone a clock time for a prescribed medicine. So, here is the honest version of that title. What the evidence actually shows about morning versus night dosing, and how to settle the question properly with your own doctor. Your blood pressure does not switch off when you fall asleep. It keeps running all night long. In a healthy circulation, the numbers fall by something like 10 to 20% in the small hours, then climb again in the hour before you wake. That overnight dip is one of the most consistent findings in cardiovascular medicine. But after 60, for a great many people, that dip quietly flattens out, and more than half of all adults past 60 are living with high blood pressure right now. Here is why that matters more than you have probably been told. You are almost always measured sitting in a chair, in daylight, with your sleeve rolled up in a clinic. What your arteries are doing during the 8 hours you spend lying in the dark is a blank space on your chart. Yet the research here is remarkably consistent. Nighttime pressure turns out to be one of the strongest single predictors we have of stroke, heart failure, and kidney damage. In many studies, it predicts more than the daytime number you have been watching for years. There is a name for losing that overnight fall. Doctors call it non-dipping. It simply means your pressure at 4 in the morning is nearly as high as it was at 4 in the afternoon. It becomes steadily more common with each decade of life, and after 60 you should assume nothing about your own pattern. It causes no symptoms whatsoever. You cannot feel it, you cannot sense it, and you will sleep straight through it, night after night, for years. So the question in your head is a genuinely good one. If the night matters that much, and the pill is the main tool you have been handed, what hour should you actually take it? 9 in the evening? The moment before the light goes off? 2 hours after dinner? You have probably heard 3 different answers from 3 different people, and at least one of them sounded very sure of himself. Let me be straight with you before we go a step further. Nobody who has not seen your chart can name a clock time for your prescription, and that includes me. That decision belongs to you and the doctor who wrote it. What I can do is hand you the actual evidence in plain English, so that when you next sit down in that room, you walk in as the best informed person in it. That is worth more than any hour I could name. By the end of this, you will understand what your arteries are doing at 3 in the morning, why that pattern shifts after 60, what the largest trials on evening dosing genuinely found, and the one factor that matters far more than the position of the hands on the clock. It is simpler than you expect. It is also not what most people assume. It will mean nothing to you until you understand the machinery underneath. So we need to start with a clock you did not know you owned. Deep inside your brain sits a small cluster of cells that acts as a master timekeeper for your entire body. It takes its cue from light entering your eyes, and it sets the rhythm for hundreds of processes, including the tone of your blood vessels. Under its direction, your body runs a daily pressure curve. It rises steeply before dawn, holds through the day, eases through the evening, and reaches its lowest point in the middle of the night. That curve is not random. It is scheduled. Picture the plumbing in your house. During the day, taps are running, the washing machine is going, and the system is under constant demand. Late at night, everything closes down and the pressure in the pipes settles. Your circulation is meant to do exactly that. As you fall asleep, the nervous system that drives your heart rate quietens. The hormones that tell your kidneys to hold on to salt and water ease off, and your vessels widen slightly. The whole system takes its foot off the accelerator for a few hours. After 63 things commonly interfere with that nightly settling. Your arteries carry more collagen and less elastic tissue, so they no longer relax as readily. The pressure sensors in your neck and chest, which report back to the brain moment by moment, become less sensitive with age, and your kidneys clear sodium more slowly than they once did, so the salt from your dinner is often still being handled while you sleep. Each one alone is minor. Together they blunt the dip. The science on this is actually very clear, and it comes from decades of a simple technology. A cuff worn for 24 hours, inflating quietly while people go about their lives and their sleep, has been used in research populations around the world for a long time now. Study after study found the same thing. People whose pressure stays high overnight fare worse over the following years than people whose pressure falls, even when their daytime readings look identical. That single finding reshaped how specialists think about this condition. There is another common reason the dip disappears after 60, and it is worth naming. Obstructive sleep apnea, said apnea, is a condition where the airway narrows repeatedly during sleep. Each pause jolts the nervous system awake for a second or two, and each jolt sends pressure upward. If you snore heavily, wake unrefreshed, or your partner has noticed you stop breathing, that is worth raising with your doctor. It is common, it is very treatable, and it is missed constantly in this age group. Now think about what this means for the tissue itself. High pressure during the day is a load. High pressure through the night as well is a load with no recovery shift. A hose left pressurized for 24 hours a day ages differently from one that is relieved every night. Your vessels were built expecting that nightly relief. But here is the part almost nobody explains to you, and it concerns one specific layer inside the vessel wall. The inner lining of every artery you own is called the endothelium. It is a single layer of cells, one cell thick, lining the entire inside surface of your circulation like the glaze on a piece of pottery. It is not passive plumbing. It is an active organ, and if you could lay yours out flat, it would cover a startling amount of ground. Everything that happens next depends on how well that one delicate layer is functioning. Its most important job is chemical. Healthy endothelial cells release a gas called nitric oxide, which tells the muscle in the vessel wall beneath them to relax. That relaxation is what lets your arteries widen when you need more blood and settle when you do not. It is the mechanism behind your nightly dip. When this layer is working well, your vessels are supple and responsive. When it is not, they stay tight by default, and the pressure in them stays up. After 60, this layer becomes vulnerable for reasons that are entirely mechanical and entirely normal. Every heartbeat scrapes blood across it. Decades of that friction, combined with the ordinary oxidative wear of living, gradually reduce how much nitric oxide those cells can produce. Meanwhile, the elastic fibers in the layer beneath fray and are replaced with stiffer collagen. So you have a lining that signals for relaxation less strongly, sitting on a wall that responds to the signal less willingly. Now follow the consequence upstream to your heart. Your left ventricle is the main pumping chamber, the muscle that pushes blood into your whole body. It must generate enough force to overcome whatever pressure sits in the arteries. If that pressure never drops, the ventricle never gets an easier shift. Like any muscle worked constantly, it thickens. A thickened ventricle becomes stiffer, fills less easily between beats, and over years that is one of the main roads to heart failure in people past 65. Follow it downstream, and you reach the smallest vessels of all. The tiny arteries feeding your kidney filters and the deep tissue of your brain have thin walls and no cushioning behind them. They take the pressure raw. In your kidneys, that gradually reduces filtering capacity. In your brain, it damages small patches of the wiring that connects one region to another, which shows up on scans as scattered white spots, and shows up in life as slower thinking, poorer balance, and a higher risk of falls. I am telling you this plainly, not to alarm you, but because it explains why the timing question exists at all. If nighttime load is the problem, then a medicine that covers the night properly is the solution, and the hour you swallow it feels like the obvious lever to pull. It is a completely logical conclusion. It is also the point where the evidence turns out to say something surprising, and we are one sentence away from it. Here is the answer, and it is not what most people expect. The best time to take your blood pressure medicine is the time you will genuinely take it. Every single day, without fail, agreed in advance with your doctor. The hour on the clock matters far less than the never missing. Consistency is the active ingredient. If that sounds anticlimactic, stay with me, because the story of how we learned it is the most interesting part. For years, the idea that bedtime dosing was superior had real momentum. A large trial in Spain, reported that patients taking their tablets at bedtime had dramatically fewer heart attacks and strokes than those taking them in the morning. The effect size was enormous, far larger than the blood pressure difference alone could explain. When a result looks too good for its own mechanism, the scientific community does what it should do. It scrutinized the trial heavily, and serious questions were raised about the conduct of that study. So the question was tested again, properly, by independent groups. A very large pragmatic trial in the United Kingdom, known as the TIME study, randomized more than 20,000 people to morning or evening dosing and followed them for years. A separate Canadian trial in primary care, called BedMed, did much the same thing in several thousand patients. Both compared real people taking real prescriptions in ordinary life. Both looked at the outcomes that actually matter, which are heart attacks, strokes, hospital admissions, and deaths. Both found no meaningful difference. Morning or evening, the hard outcomes came out essentially the same. What they also found is reassuring in its own right. Evening dosing was not dangerous, and it did not cause the excess of dizziness or falls that some had feared. In other words, the profession spent a decade arguing about a lever that turns out to be far less powerful than the arguing suggested. Most people assume the hour is decisive. The best evidence points somewhere else entirely. The mechanism behind that finding is simple once you see it. Nearly all modern, once-daily blood pressure medicines are engineered to hold a steady concentration in your bloodstream for a full 24 hours and a little beyond. That deliberate overlap is why a single tablet can cover both your night and your morning surge. The drug is not a switch you flip at a moment. It is a level you maintain. Shifting that level by 8 hours barely changes it. Dropping it to 0 changes everything. And that is where the real risk sits. Skipping a dose does not shave a small slice off your protection. It creates a genuine gap, and the gap is usually longest overnight, precisely when you are least able to notice. Missing 2 doses a week means your arteries spend roughly 100 days a year less protected than you believe they are. No adjustment of the clock can compensate for that. This is the single most common reason blood pressure stays uncontrolled after 60, and it has nothing to do with the medicine failing. Now remember the endothelium, that one-cell-thick lining I described a few minutes ago. It does not respond to a single dose. It responds to the average load it experiences across weeks and months. Feed it steady, well-controlled pressure, and its nitric oxide production improves measurably over time. Feed it a sawtooth of good weeks and forgotten days, and it stays under strain. Your arteries are keeping a long-term average, not a daily diary. Consistency is what moves that average. This is also why chasing the perfect hour beats out so poorly against the alternative. If you move your tablet to 10 at night because you read that bedtime is better, and 10 at night is a time you sometimes fall asleep before reaching, you have traded a benefit the trials could not detect for a loss the trials measured clearly. The best schedule is the one that survives contact with your actual life, including holidays, illness, and the day everything goes sideways. There is one honest exception worth knowing. Some people have a specific reason to shift timing, and it is a clinical decision. A doctor may want an evening dose if your overnight readings are genuinely high, if daytime dizziness is a problem, or because of how a particular drug behaves. That decision needs your full medication list, your kidney function, and your history in front of them. So the useful question at your next appointment is not what time is best in general. It is what is best for me, given what I take. Now that you understand why, let us talk about what to do tonight. The first thing is to anchor your dose to something you already do without thinking. Not to a time, to an event. Beside the kettle you boil every morning. Next to the toothbrush you reach for every night. Human memory for clock times is poor, especially when the days blur, but memory attached to an existing habit is extremely reliable. Choose the anchor that never moves in your week. Second, use a weekly pill organizer with a compartment for each day, and keep it in plain sight rather than in a cupboard. The value is not the plastic box. It is that you can see, at a glance, whether Tuesday was taken. That removes the worst situation in medicine safety, which is standing at the sink, genuinely unsure. If you live alone, a repeating alarm on your phone at your anchor time costs nothing and works well. Third, learn to measure properly at home, because your own numbers are worth more than any general rule. Use an upper arm cuff rather than a wrist device. Sit with your back supported and both feet flat on the floor. Cuff on bare skin at the level of your heart. Sit quietly for 5 full minutes before you start. Take 2 readings a minute apart and write both down. Do it at the same times each day and bring the log to your appointment. Fourth, if the night is what concerns you, ask specifically about 24-hour ambulatory monitoring. That is the cuff worn for a full day and night that I mentioned earlier. It is the only way to actually see whether your pressure dips while you sleep, and it turns this whole conversation from guesswork into data. Availability varies by country and by clinic, but after 60 it is a reasonable thing to ask about, particularly if your readings are inconsistent. Fifth, agree your missed dose rule in advance. Ask your doctor or your pharmacist now, while nothing is wrong, exactly what to do if you realize at lunchtime that this morning's tablet is still in the box. The answer differs by medicine. Having it written on a card in your kitchen means you never have to improvise, and it means you never take 2 to catch up, which is the instinct almost everyone has and the one to avoid. Here is the thing people most commonly get wrong, and it is entirely understandable. Many stop taking the tablet, or quietly have it, on days when their reading comes back normal. That reading is normal because of the tablet, not instead of it. Blood pressure medicine is not a painkiller you take when you feel it. It is more like the tension on a bicycle brake cable, maintained continuously so that it is there the moment it is needed. A word of genuine caution on a few situations. If you have kidney disease, if you take medication for diabetes, blood thinners, or tablets for your prostate, or if you use anti-inflammatory painkillers regularly, the interactions here matter, and your doctor needs to be the one weighing them. And if you feel lightheaded when you stand up quickly, tell them. That is called orthostatic hypotension, a drop in pressure on rising, and after 65 it is a real fall risk that can usually be fixed by adjusting what you take or when. Now, the last obstacle, and it is the one that undoes more overnight blood pressure control than any dosing schedule ever could. The evening drink. Not heavy drinking. The single glass of wine or the small whiskey that thousands of people past 60 used to mark the end of the day and help themselves drift off. The mechanism by which it works against you is precise, and almost nobody is told about it. Alcohol widens your blood vessels for the first hour or two, which is why you feel warm and relaxed, and why a reading taken then may look fine. Then it reverses. As your body clears it, the nervous system rebounds into overdrive, your heart rate rises, your vessels tighten, and the effect peaks in the middle of the night. Alcohol also fragments the deep sleep stages and relaxes the muscles of the throat, which worsens snoring and breathing pauses. It lands squarely on the hours your pressure is supposed to be at its lowest, so the fix is not necessarily to give it up, it is to move it. Shift the drink earlier in the evening, ideally with food, and leave 3 or 4 clear hours before bed, so the rebound falls before you lie down rather than during your deepest sleep. Build in several alcohol-free nights each week, and watch your morning readings across a fortnight. And if you have been using it to fall asleep, that is worth mentioning to your doctor, because there are better tools for that. One thing needs saying clearly before we finish. Blood pressure is a slow condition, but a few situations are not. Crushing chest pain, sudden weakness or drooping on one side of your face or body, sudden difficulty speaking, sudden loss of vision, or a severe headache unlike any you have had before are emergencies. Those need an ambulance the same minute, not a home reading, and not a wait until morning. Everything else in this video is for the long game. If you remember one thing tonight, remember this: the tablet you take at the same time every single day, without fail, protects you far more than the perfect hour ever will. If this was useful to you, subscribe, because this channel exists to explain the things. There is never enough time to explain in a 10-minute appointment. And tell me in the comments, Do you take your blood pressure tablet in the morning or at night? And did anyone ever explain to you why? You are not powerless here. You are dealing with one of the most understood, most treatable, most controllable conditions in all of medicine. And the levers that matter are ones you already hold. Take it consistently. Measure it properly. Move the evening drink earlier. Ask your doctor the specific question about your own timing rather than the general one. Everything in this video is for general education and is not medical advice. Please talk to your own doctor before changing anything about your diet, your medication, or your routine.